Thank you very much for joining us today as we look through the roundtable prostate cancer care, a roundtable for GPs. The role that radiation oncology can play and also surgery in this patient group. My name is Liam Butler and I'm the Managing Director of RxTro. At the end of this, we hope we'll leave with a better understanding of how to enhance care pathways between yourself and specialists and how to manage these men on ADT. We know by completion of the registration of surveys that many of you in general practice very rarely initiate these therapies, however, are often having to manage these patients day to day. Today, we'll be discussing the important role of androgen deprivation therapy, or ADT, in prostate cancer management, particularly in rural settings. And we really want to focus on the skills, training and education for GPs to confidently manage these patients requiring ADT, as well as clearer pathways to specialist care for these patients. To introduce the panel, I'd like to introduce Dr. Shankar, radiation oncologist at Icon Cancer Care. Welcome, Dr. Shankar.
Thanks very much.
Dr. Shankar, if you could just give us a little bit of a brief introduction to yourself.
Yeah, of course. Thanks very much for hosting to RxTro and to AbbVie. So my name is Dr. Mihir Shankar. I'm a radiation oncologist with Icon Cancer Care based out of Redlands, Greenslopes and Auchenflower. So my subsite specialty interest is in genitourinary malignancies, and I did an overseas fellowship in this recently and then returned to Australia. So very, very grateful to be part of the panel.
Fantastic. Also today, we have a general practitioner joining us, Dr. Jeff Whitby. Welcome, Dr. Jeff.
Yeah, thanks, Liam.
Fantastic. And Dr. Whitby, if you could just give us a little bit of background into your professional experience.
Yeah, certainly. So, Liam, I've been working in general practice about 7 years now. I work in a practice in metropolitan areas north of Brisbane. But over the last 2 years, I've been doing a GP with special interests position at the Royal Brisbane Hospital. So working in clinics there. I've been involved in seeing patients right from the initial high PSA referrals right through the post-treatment phases. So see the wide range of what's going on there.
Fantastic. Excellent. And finally joining us on the panel today, Dr. Navaratnam, urologist at Brisbane Prostate Care. Dr. Anno, welcome to the webinar.
Oh, hi, Liam. Thanks for that. Yep.
Fantastic. And Dr. Anno, if you could just give us a little bit of background into your experience.
Oh, yep. So I'm a urologist up in Brisbane. I have subspecialty sort of interest and expertise in GU oncology. Obviously, prostate cancer has there's a large part of my practice is prostate cancer. I've done a fellowship at Mayo Clinic back in 2017 for a couple of years, so I've been back for a while now. I've practiced mostly out of St Andrew's War Memorial Hospital through Brisbane Urology Clinic, as well as the Royal Brisbane Hospital as well.
Fantastic. Look, thank you very much for that. Well, look, maybe if we can start with you, Dr. Whitby, taking a patient example. As an example, an elderly gentleman who had a previous prostatectomy and now his PSA is starting to rise again. Dr. Whitby, as the initial point of contact for this patient, what are your immediate considerations and next steps, and how would you approach this, and where would you consider specialist referral?
Yeah, so if this was a patient that had been handed back to myself for PSA monitoring, if I was seeing that PSA suddenly jump up and rise, I would have that concern that he's had recurrence of his prostate cancer. My likely next step would be organising further scans. Look, in metropolitan area, I find that initial scan referral is easy to get done through the specialist system. So I'd often talk about referral back to a urologist at that point, concerning that he's got biochemical recurrence of his prostate cancer.
Fantastic. Thank you, Dr. Whitby. And Dr. Anno, once this patient is referred to a urologist, what are your next steps in assessing this rising PSA post-prostatectomy?
Yeah, I think with everything, what is the definition of a biochemical recurrence following prostatectomy? So, the definition of that is a rise of PSA 0.2 above whatever the nadir PSA was. So often after prostatectomy, we do see some patients with persistently detectable PSAs. But as long as the kinetics are sort of staying flat, it's not a major concern. But ideally, we want them to be completely undetectable. So, on Sullivan Nicolaides in Queensland, it's less than 0.008, QML 0.01. So we're picking up PSAs at very low levels these days. And interestingly, in America, most of the assays over there still only detect things at 0.1. And so we leave things to 0.2 because it's basically been shown, in retrospective data sets that there's very unlikely to be clinically significant cancer recurrence at a PSA below that level. So I think when I see these patients, start with a history, just make sure they don't have any symptoms of, overt metastatic disease. Obviously, a gentleman who's got a very low PSA is unlikely to have any symptoms whatsoever. Looking at their previous PSAs, what it was immediately after their prostatectomy. I think asking for symptoms of urinary infection, that can still sometimes cause, little rises in PSA if they've got some benign prostate cells on their bladder neck still. And then I guess the decision is who do we send off for consideration of salvage radiotherapy, and, which patients we get further imaging on with staging. So, a cutoff of 0.2 is probably the point you'd think about doing a PSMA PET scan to exclude any extra pelvis or metastatic disease. So depending on what the level of the PSA is, probably either surveillance of the PSA, a PET scan, and then possible on referral, depending on how their PSA behaves. And that's either to a medical oncologist or a radiation oncologist, depending on what the PSA does.
Fantastic. And Dr. Shankar, if radiation therapy does become a consideration for this patient, what would your discussion with the patient involve, and what role would ADT play in conjunction with radiation in this scenario?
Yeah, thank you. So with just following on from what Dr. Anna was saying, a lot of this discussion, you really do a very comprehensive assessment of a lot of different factors when sort of making a decision whether there is a role for radiotherapy. The kind of things that we're looking for are the trajectory of the PSA, the timing after the operation, and also certain risk factors associated with the histology from the original prostatectomy specimen. A lot of the guidelines do sort of advocate consideration of salvage bed radiotherapy above a certain threshold, and this is even if the PSMA PET doesn't demonstrate any sort of local or residual avidity. And so a lot of my discussion with the patients usually is very much around stratification of risk and timing, and you're really trying to sort of knuckle down what is the source of the PSA increase. Is it residual disease potentially in the prostate bed? There's always going to be a subset of patients who will have a persistently high PSA after an operation, and that necessarily is not a concern if the overall trajectory is largely stable. And then also is a discussion really around the overall comprehensive management, whether it involves radiotherapy just to the prostate bed, if that's sort of considered to be the highest risk source of the PSA increase. Should we involve the pelvic lymph nodes as well in a setting where there was no lymph node disease initially? And then sort of coming to the role of ADT overall. So practice really does vary quite a bit. We know from some of the evidence over the last decade or so, there is an overall benefit to a short course of androgen deprivation therapy of about 4 to 6 months as part of any radiation therapy regimen if we are going down this route. And so there were studies all the way from back in 2016. We know that the addition of ADT even for 4 to 6 months as part of a radiotherapy regimen in a post-prostatectomy situation improves biochemical recurrence-free survival. We know from some of the more recent data with there's a study called SPORT, which showed that there's also a distant metastases and a progression-free survival in the order of about 8% in terms of an absolute benefit. And then there's a study that came out just last year called Radicals HD, which tried to look at if there was a benefit to doing short course of ADT versus long course of ADT. So in the absence of there being any nodal involvement, we know that even in sort of the moderate to high risk patients with Gleason 7 disease, or if there was extra capsular extension on the original prostatectomy specimen, there is going to be a benefit to ADT across the board. So generally my discussion with the patient generally sort of revolves around that. It's deciding on the appropriateness for radiotherapy, what exactly we'd recommend treating. But then more often than not, if we do make a decision to go down that pathway, I would always usually recommend a short course of ADT at least, unless there were some contraindications otherwise.
Fantastic, fantastic. Maybe just opening it up, Dr. Whitby, in your experience, what are the primary challenges you've observed in managing patients with rising PSA post-prostatectomy in general practice? Dr. Whitby, you're on mute.
So look, challenges in managing the PSA in particular is that grey zone where they've got this slowly rising PSA and trying to decide what point when to refer to the specialist. Often working in the urology clinics as well, especially the asymptomatic patients, I'm more comfortable holding on to them for a bit longer in my GP clinic, but certainly doubling time is a good thing to go by. And if that's getting down to 12 months, 6 months, then that's even before you get to that PSA of 0.1, it's probably a good stage to be thinking about referring on to a specialist.
Fantastic. And just following on from that, to the two specialists in the room, I guess probably the question for the both of you, from your perspective, what are the key diagnostic steps that a GP should be evaluating with a patient with rising PSA post-prostatectomy? Maybe if we start with you, Dr. Shankar.
Yeah, and I think it's the steps we've already mentioned. So it's an assessment of the PSA doubling time and trajectory. A PSMA PET scan is a really important part of the overall staging. The sensitivity of a PSMA PET scan is highly dependent on the PSA at which it's tested at. So generally the recommendations are that we should do testing at about a level of 0.2 and above, but the overall sensitivity at really detecting I guess local, regional or distant disease there is sitting relatively low at about 20 or 30%. But that's not a reason to not do the scan nor to follow up appropriately. The other thing that is generally valuable, particularly if patients are proceeding to radiation and sometimes even otherwise, is doing an MRI scan to try and identify if there is any visible or radiologically evident disease within the prostate bed, which really does assist with radiotherapy planning, particularly if there's a view to giving a little bit more of an aggressive radiation dose to certain areas. So they're sort of the three main things.
Fantastic. Anything further to add to that, Dr. Anno?
No, I think I agree with everything that's been said. I think, probably the biggest thing as a GP you can do for your patients is probably appeasing a lot of the anxiety as well. Just because a PSA has become detectable it often doesn't mean that the cancer's back. We're picking these things up at such low levels that, it's generally something that's it's a bit of a process after that initial step, and biochemical recurrence doesn't necessarily equal, poor cancer specific survival or poor outcomes for the patient. So I think appeasing that anxiety is probably a big thing while they wait to see one of us.
Fantastic. Excellent. Well, look, maybe just moving forward in the patient's journey. Dr. Shankar, if the patient then does proceed on with salvage radiation, what does their journey typically look like, and what ongoing monitoring and support would you want from a GP?
Yeah, that's a great question, and thanks for directing to me. So the journey itself for the patient, really after the comprehensive discussion and investigations, and if a decision is made as part of a multidisciplinary team to go ahead with radiotherapy, generally depending on the timing since the operation, I'll usually stratify the timing of the radiation to that. one of the issues with doing the radiation too soon after surgery can sometimes be there's quite a significant risk of exacerbating lower urinary tract symptoms, particularly if done in the short term. So usually in those instances, I'll start ADT up front, at least to give a few months time for greater postoperative recovery before scheduling in radiation. If it's been an adequate, substantial amount of time since the operation, we can often do ADT and radiotherapy starting largely concurrently. And so sort of the journey will probably really begin with the ADT being prescribed, and generally for these, I'm very grateful for the patient's GPs to very much be aware that they are starting the androgen deprivation therapy, and as well as being able to administer it, and also to assist with counselling and some of the side effects of things. So I usually run through quite comprehensively the expected side effects of ADT, which, large proportion of patients will have hot flushes, a little bit of weight gain, muscle wasting, fatigue, sexual dysfunction, and a lot of these things, really do require quite a lot of support from primary care, and for these things, usually, I'm very, very grateful for a lot of the support, and those are the kind of main things to be looking out for the patients on ADT. Following this, from a radiation perspective, patients will undergo what's called a simulation or a planning scan. So that essentially involves a little bit of a preparation process where we sort of train them to sort of hold their bladder in a bit of a neutral position, and enter a daily sort of bowel preparation regimen for the setup. The simulation scan goes for about 1 hour, and then the radiotherapy treatment is usually delivered for a period of about 5.5 to 6.5 weeks. So logistically, it's a little bit taxing on patients, which is another avenue where, really do appreciate the support from GPs to sort of really assist patients with managing logistics, and also, as Dr. Anna mentioned, managing a lot of the anxiety and psychosocial supports around the entire treatment journey. So treatment itself being, daily treatments, 10 to 15 minutes a day for on the order of 6.5 weeks, is quite taxing on anyone. And then usually there's a period after that where the side effects from the radiation treatment are principally genitourinary, and a lot of the management of that can, again, have quite a big quality of life impact. So I'll follow these patients up quite closely just from a symptom management point of view. After the radiation finishes, the symptoms usually peak at about 4 to 6 weeks after the treatment, and then start alleviating it by about 3 to 6 months. And so it ends up being, cumulatively quite a substantial treatment regimen. It's not just, I guess, the radiation, but essentially from the start of the ADT being administered to almost 6 months after treatment finishes. That's kind of where there's quite a large degree of support required.
Fantastic. No, thank you very much. And Dr. Anno, if the patient's pathway leads to ADT as the primary treatment, what do you think the patient requires most from their GP and other allied health services for ongoing management? And I guess, probably, what have you seen work well from your experience, potentially both in public and private?
Yeah, I think what Mihir sort of spoke about, monitoring of side effects, I think a lot of the there's a lot of support from the pharmaceutical companies now for these drugs, with access to, psychological care, exercise physiologists. So the allied health aspect of it is very important. So, making sure that men have been signed up to all these programs when they're on ADT, it's all there. It's all well funded by the pharmaceutical companies. So, for example, with, obviously AbbVie supporting this one, the MAN plan, these things are pretty easy to enroll patients on too, and sort of take a lot of that work out of your hands as well. So that's what I'd suggest.
Fantastic. And Dr. Whitby, building on that, what practical advice do you have GPs regarding day-to-day monitoring and support for patients, particularly given that GPs are often the ones managing these patients long-term?
Yeah, indeed. Look, patients especially the long-term patients on ADT, you'd often have that quick as they're coming in for the next, to get their ADT and organising their next scripts. You have that conversation about side effects. So usually you have that general conversation of any problems, but then I usually nail them down with a couple specific, especially about sexual dysfunction. They're not always is willing to volunteer problems in that regards. And you can initiate some trial some PDE5 inhibitors, or even if they're willing, cavernosal injections and so forth, to see if they're effective in managing those side effects if they're bothersome for the patient. But the other one I usually am quite like to be quite proactive about is all the bone density testing, and the men who are going to be on long-term ADT, being involved in that and organising a baseline and any follow-up bone density scans, I think is pretty important for these guys. And the other big one is making sure that they have got a exercise plan in place, just reiterating that need for weight-bearing exercise. So, and then maybe managing the chronic disease medical management plans, and accessing exercise physiologists through that I find it very helpful for the patients.
Fantastic. Excellent. And maybe just a question for each of you. I guess from each of your unique perspectives, how can we ensure clear communication and coordination of care across GPs and specialists when drugs like this are being managed? And I guess probably in each of your opinions, what's the ideal communication pathways and share care models? Maybe if we start with you, Dr. Whitby, as the first point of contact.
I still enjoy letters. I think letters are a good way of communicating with each other. But urgent things, often a phone call to the treating specialist, I find very helpful, just to keep them up to date with what I'm doing and what they're doing, so we can all be on the same page when managing it.
Fantastic. And Dr. Anna, what are your thoughts around that topic?
Yeah, I think, written communication is probably the key. But, it's sort of empowering the patient as well, that they're involved in the decision-making and the treatment process. I think that's pretty important with cancer patients, is that they take a bit of ownership, and, there's always reasons for things to potentially fall through the cracks. So they need to know that, if we've prescribed something, then you need to do follow up X, Y, and Z with your GP. So I think letters, using, prostate cancer nurses, most hospitals have them now as a point of coordination, is a good idea as well.
Fantastic. Anything to add to that, Dr. Shanker?
No, I think agree with everything that's been said so far. That's all very, very spot on.
Fantastic. Excellent. Well, look, on that note, love to introduce you to the sponsor for today's webinar, AbbVie. I'd love to welcome Miranda Button to the stage, Brand Manager for Urology, just to give a short presentation around Leukeran.
Thank you, Liam, and thank you for this opportunity all. So if I start with Leukeran, and I guess why Leukeran when there are alternatives in the market, potentially 3 good reasons. Durability around the product. So whether we're talking the 1, 3, 4, or 6-month dose, we know that efficacy is really high and comparable across the options. Reason number 2 is it is convenient, and I will come back to that in a second. And reason number 3 for Leukeran would be around support. So if we talk convenient briefly, we know that the 4 doses available for Leukeran give flexibility to patient lifestyle and clinical needs, and a really small level of volume in regards to when it's being administered generally in general practice. And the second reason around convenience is the simple administration. So it's a 2-step process of just release and swirl. And so very easy for whomever is giving it, and obviously for patient comfort as well. And on top of that, Leukeran does have the smallest needle gauge in this market. As you can see there, a 23 gauge needle across all doses, and an IM delivery system. In regards to support, which I mentioned up front and has just been spoken about in this discussion, is around wellness for the patients. So the Man Plan program, as Dr. Eno alluded to, is a patient support program for any patient on Leukeran. It has been going for 16 years and has had over 10,000 patients enrolled into the program. So what is the MAN plan? The whole aim of the MAN plan is to mitigate some of the side effects that we can see in regards to androgen deprivation therapy. And so what we're focusing on is exercise with the MAN plan, and patients have the option to either exercise face-to-face at a local clinic to them, or virtual, live virtual, like we're online now, with an exercise physiologist or physiotherapist. Patients also have access to a dietitian. And then there are many services with the online portal as well with the MAN plan. So if I'm just to reiterate, 3 really good reasons in regards to why Leukeran: durability, convenience, and support of product. Thanks, Liam.
Fantastic. Look, thank you very much for that, Miranda. Maybe just taking a little bit of a change of pace now. We've obviously talked about diagnosis, initial ongoing management. Maybe just switching to managing the side effects around ADT, and I guess probably a question for the broader panel. Are there any specific strategies or resources you'd recommend for managing the side effects of ADT? Yeah, particularly the hot flushes, fatigues, or bone health concerns? Maybe if we start with Dr. Anna.
Yeah, they're difficult to manage. I mean, I think, you know, bone density wise, getting a baseline scan and just making sure that they're engaging in as much physical activity as possible, and you know, instigating bone health support strategies when it's appropriate, either with just calcium supplementation or you know, denosumab, some of those medications. I think with the hot flushes, that's very difficult to manage. You know, using intermittent therapy, adding certain androgen receptor blockers, like, you know, old-fashioned Androcure or cyproterone, you know, can be a strategy to help with that. But yeah, the hot flushes are difficult to manage. It's not something that we sort of encounter a lot of, because often these patients have moved on from our care. So I'm certainly, you know, willing to learn from the other panelists as to strategies that they may have.
Yeah, no, look, well, absolutely. Well, maybe it sounds like with that we should speak to Dr. Whitby.
Yeah, no problem. Look, yeah, Anna, you're absolutely right. The hot flushes can be quite bothersome. A lot of men are tolerant of it, but I've found the non-medication. There's actually on the Prostate Cancer Foundation website, they've got a really nice list of things that patients can try: loose-fitting clothing, lighter sheets. Simple interventions like this can be helpful to patients, and sometimes you hit on something that just triggers with them really well, and they can find it helpful. Look, in regards to other side effects, the erectile dysfunction, often men are just accepting that it's part and parcel with it. But I often like to have that conversation with them, just to see if it's a big issue in their lives, if it is affecting their whole psychosocial dynamic. For some men, it's still a very important thing, and so trying medications, trying injections, and just opening up the ideas of things like vacuum pump devices, or even it can be eye-opening to them, just to put that in their minds and something to think about.
Fantastic. And Dr. Shankar, anything to add to that?
Yeah, no, I agree with everything that the other panelists have said so far. I think, you know, with these kind of things, they're so sort of multifaceted in terms of the side effects, and you really are managing, you know, a combination of physical and psychological and social. And, you know, there are certain things that are very important to patients, such as sexual function, which can be quite debilitating on quality of life. And And for other things, it can just be things like the fatigue and the weight gain. So usually with these, I have a discussion with them about conservative measures. We've already touched on exercise programs, bone mineral density, and then there's a nutritional aspect to that. So just ensuring that they're at a very basic level, just ensuring adequate nutrition to ensure good bone health and good systemic health. Certain risk factors are going to be exacerbated by ADT, whether it's not as much in the short term, but certainly for the medium to longer term ones. So general cardiovascular health, I'll always recommend they have a discussion with their GPs about optimizing things like cholesterol, blood pressure, things like that. In terms of the psychological supports, there are obviously a number of different psychological supports that are available, and generally, again, I'll have a discussion with them about some of the options available and encourage them to again speak more to their GP about it, or if they're interested in having a referral for certain programs, I'm very happy to facilitate that as well. And then I suppose from the medication side of things, for the individual side effects, I guess we've touched on sexual dysfunction, and there's a number of interventions that can be done for that. Agree with Dr. Whitby, a lot of patients are very much acknowledging that it is a known effect of being on ADT, and for a large part, it's something that we hope is going to be fairly short-lived, or at least the exacerbation of it is going to be short-term. From the hot flushes perspective, as Dr. Anno said, I'll often sometimes, particularly to mitigate the flare initially, I'll prescribe a short 2-week course of bicalutamide or sapropterin or some of the older anti-androgen drugs, which tends to minimize some of the hot flushes in the initial period of the injections. Longer term, there are drugs that have been pretty well established, like venlafaxine and things, but they do come with their own side effects. And a lot of times when I have the discussion with patients about, this is an option if it's causing you particular debilitation, they often think the side effects of venlafaxine are worse than the hot flushes themselves. So 9 times out of 10, they'll be happy to continue, just on the course. So lots of different facets to it, and I think really just individualizing to what's important for the patients.
Fantastic. Look, thank you very much for that. Now, to the audience, we are going to just finally touch on GP specialist collaboration, but we have allocated some time for questions and answers at the end. If you do wish to ask a question of anybody on the panel, you'll see there's a Q&A button on your Zoom webinar. You can open that up, you can ask the questions, and we'll come back to those in about 4 or 5 minutes. Before we jump onto that, though, as I say, really like to focus on obviously GP specialist collaboration at the end. So really a question sort of for the panel, and thinking about particularly GPs in rural settings, how can specialists, I guess, better support GPs in managing these patients, considering the unique challenges that potentially people in rural settings face? Maybe if we start with you, Dr. Whitby.
Right. Look, I don't work in a rural setting myself, but you can certainly appreciate the added restrictions in working in those areas. I just had a patient today who was a very similar presentation, and his GP's done a great job in managing him, and has been quite proactive in managing a biochemical recurrence. And I think with the help of a specialist, initiated the patient on ADT himself. Patient was very happy with this. So I think even a rural setting, it's more that the GPs will play a much stronger role, as there can be a bit of delay in time getting to see those specialists. And so considerations of doing more of the workup early, organising scans and so forth, can be very helpful in moving the patients through the stages and onto active treatments earlier.
Fantastic. And Dr. Anno, your thoughts around obviously how specialists can better support GPs in a rural setting?
Yeah, I think pretty similar to what Jeff said, but again, using sort of the community points of contact with nursing and allied health. Pardon me. And I think, something in a regional setting, and something we've sort of had lots of discussions about is, running a sort of advanced prostate cancer clinic for those patients who have who are on these medications and need the extra support. Just having a clinic run that way, either with allied health support or GPs with special interests. That's probably the ideal way to deal with these issues in the long term, and certainly something that we're sort of starting to have a think about looking at.
Fantastic. And Dr. Shankar, any further thoughts around that?
Yeah, no, I think agree with everything that's been said. I think just the infrastructure and access is probably quite important, and I think if there can be facilitated pathways to reach out if any specialist advice is needed, but at least to get a response expeditiously, that's something I think is tremendously valuable for patient care in rural and regional settings. And so I'm usually always a very big advocate of being very easily accessible if needed, particularly for colleagues in rural and regional areas.
Fantastic. Excellent. Well, look, thank you very much for that. As I say, we have allocated some time to run through some questions, and there have been a series of questions that have come in. One of the first questions that's come in is the management of partners or carers and what consideration that has. Maybe starting with Dr. Whitby.
Okay, managing partners and carers. Often it's, and I see this, especially female partners coming in, the impacts on them as well. So sexual side effects can be an impact on their relationship, and not just in a negative way. Often they're trying to be supportive, and that not getting through to the male partner can also be a big impact. So often having partners along at consultations and instigating those more intimate discussions can actually be, I've found that very beneficial for patients. They're sometimes reluctant to have those conversations at home, and starting them at the consult can be a good way to break the ground on that.
Fantastic. Any further thoughts around that, Dr. Shankar?
No, I think that's a great point. I think just having the proactivity to engage in that discussion at the point of care is agree it's something that'd be very, very valuable.
Fantastic. And Dr. Hanna, nothing to add to that? Or?
No, I think it's, most guys will rock up to these appointments on their own, and they'll come for follow-up on their own. So I think just as the health care, clinician, just telling them, it's okay to have your partner here, and you should really have your family here for the initial consultations at least.
Fantastic. Excellent. Look, another question that's come in relates to, are there different support services available for private compared with public patients receiving ADT? For example, where would a patient go to get their ADT injection? Maybe starting with yourself, Dr. Anno.
Yeah, there shouldn't really be a difference in public versus private. I think, the shared care model we use in both settings, probably where things can sometimes be a bit different is, speed of communication. A letter with plans from my public outpatients may take up to 4 weeks, whereas, from my private practice will be hitting the GP's office through medical objects or electronically within 24 hours. So I think that's probably the main thing. But again, I think that's where it's important to engage the patient, give them some basic handwritten instructions as to what needs to be done, particularly when commencing ADT. So, usually what will happen is that we'll give them the script for the injection, commence them on the androgen receptor blocker, and just tell them, look, you need to go see your GP in 2 to 3 weeks with the injection and get this delivered. privately, you know, our clinic's sort of set up to have, we've got a number of nurses that will do that if the patient's going to struggle to get into their GP. But again, it's just about having the patient involved, you know, in what's going on so that they have a point of contact if there's any problem.
Fantastic. And Dr. Schenker, any further thoughts on that one?
No, I agree with that entirely. I think that there isn't a big discrepancy between the public and private. Agree communication times can be a little bit slower for letters to go out in the public system. But I think we usually mitigate that by just having the very detailed conversation with the patient, with sort of a very comprehensive follow-up plan. And as Dr. Ano said, there's the support systems within private and public are both excellent. We've already mentioned the pharmaceutical companies themselves also do offer sort of injection services at home for patients who might not be able to facilitate that themselves, and there's other types of support that are generally available to all patients.
Fantastic. And just finally, Dr. Whitby, anything else to add to that?
Not a great deal to add, but just reiterating what Dr. Navaratnam and Dr. Schenker have said. Yeah, look, from experience from both sides, working in the GP clinic and working in the public urology clinics, yeah, I do get the feeling that there's very similar levels of support and care in both private and public practices. But just that speed of communication coming from the public clinics. I'm aware of it also when I'm working in the public clinics and the urology clinics, and just empowering the patient to be aware of what's required as a bit of reliance on them as a backup is quite important.
Fantastic. Well, look, with that, we'll bring this to a close. So, look, just a big thank you once again to our panel, Dr. Navaratnam, Dr. Whitby, and Dr. Schenker. Thank you very much for your time. Hopefully for the audience today, this has given you a bit more of an understanding and a practical understanding of ADT patients, their journey from specialists to GPs, and most importantly, what patients really need once back at their GPs. Thank you once again, and we'll see you next time.
Thanks a lot.